Good day, everybody. This is Chris with The Ancient Scholar. I hope this video finds you all doing well. Okay, so let's go ahead and get started. This is the second video in a series of videos I'm doing on STEMI equivalents, and I think this is going to be the most appropriate video to kick off a deeper dive into the mimics, at least in reference to the article I covered in the first video, because for many of us, we are approaching the first day of winter, if not have already crossed that threshold if you've watched this video a little later on, or if I was delayed in uploading the video. And I think the most appropriate title for this video would be "The Winter is Coming," and that's in reference to the finding that I'm going to be talking about, something referred to as De Winter's T waves. I'm going to be relying heavily upon ECGs from an ECG-related website known as Life in the Fast Lane, or LITFL. This is an incredible ECG reference, and if you are not aware of it and you've never used it, and you are at all interested in cardiology, or cardiology is at all relevant to what you do, I would strongly encourage you to bookmark this and use this site, because it has some incredible references and some incredible material, and I'm going to be using some of these pictures and diagrams under a Creative Commons license, and so I do want to reference that real quick, and that's Robert Butner and Ed Burns, De Winter T-Wave article in Life in the Fast Lane, and this was accessed a couple days ago on December 18th, 2022, and you can see I have referenced the website here as well. And if you want to take a deeper dive into De Winter T waves and look at several examples of De Winter T waves, I strongly suggest you check that link out, because the article is very good and a pretty comprehensive overview of this phenomenon. Okay, so up here at the top, I have a normal or relatively normal ECG. This is actually an ECG that has been done on me. So you can see that you have a relatively normal looking ECG. There actually is a somewhat abnormal finding, or maybe we could call that a normal variant, something called benign early repolarization, which can cause some subtle ST elevation. But I'm not going to focus on that in this particular video. But what I want to talk about is the fact that there are not obvious findings suggesting problems in this ECG. And most specifically, I just want to quickly reference the J point, because that is a critical concept to understand when it comes to identifying the more classic STEMI pattern and these more subtle or less talked about in many circles patterns of mimics, and all of which can impact the ST segment. So if you remember, we'll just go to augmented vector front here, or AVF. I'm going to circle that complex there. So you've got your P, QRS, T complex. And where the QRS complex ends and it goes back to the isoelectric line and the T wave begins, I'm going to put a red in there. You can see that it makes somewhat of a J. And that is what we refer to as the J point. It's kind of a backwards J that it makes, but that's called the J point. And that J point should come to baseline. And so when you look at the isoelectric line right here, I'll go to lead 3. You've got your baseline, and I'm just going to draw this through. All right, so you can see that the J point returns to that baseline before the T wave begins. And that is what we normally want to see. Now, if that J point is instead above the baseline, so let's go to the precordial leads here. Precordial leads are V1 through V6, and specifically I'm going to look at V3 here. Here is the isoelectric line, and I'm going to draw that through the QRS complex. And you can see that that J point is now about a millimeter above, a little less than a millimeter above that baseline. And that is what we call ST elevation, or STE, when the J point, where the QRS complex ends and should go to the baseline, and the T wave will then begin. When that is above the baseline, we call that ST elevation. And this ST elevation is what we classically look for when we are concerned about something called a STEMI, which I alluded to in the last video. Now, I am not, in fact, having a STEMI with this ECG. I actually have a condition referred to as benign early repolarization, which is fairly common in younger, healthier people. It's a fairly common finding, and in the absence of any other risk factors or disease or anything like that, it's generally just considered a benign finding for the most part. But I wanted to demonstrate that the concept of ST elevation and point that out because it is relevant when we talk about some of these other STEMI mimics. Okay, so let's move on. So let's just talk about de Winter's T waves and what they are and what they represent. So first of all, de Winter's T waves, or de Winter T waves, have been around for a long time. They were first reported way back in the 1940s, actually 1947, by Pressler et al. And there's some really good pictures of this, of I believe they used X-ray photographic plates to obtain these in people having chest pain. And so they just saw them and they reported them, and not a whole lot was made of it other than that. And then in 2008, Dr. de Winter reported in a series of cases that approximately 2% of the time, people that had occlusion, proximal occlusion of their left anterior descending artery, their LAD, approximately 2% of the time, these patients presented with this now called de Winter finding, or de Winter T wave abnormality. And then approximately a year later, this was replicated in another series of case studies by Verondin et al. And they found pretty much the same thing. Approximately 2, maybe 3% of the time, people that have complete occlusion of the left anterior descending artery will not present with the classic ST elevation in the precordial leads, but rather this odd de Winter T wave finding. So what do we want to know big picture? Well, we want to know that de Winter T waves are seen in approximately 2% of proximal left anterior descending occlusion, or LAD occlusion. These T waves may precede or follow the more classic ST changes, right? So you can have a situation where these de Winter T waves can occur, and then they can transition into the more classic ST elevation, or you may present with ST elevation that then transitions into de Winter T waves and back and forth, and you can have lots of dynamic changes occurring back and forth going on. These may lead to delayed or inappropriate treatment because de Winter T waves have not classically been thought of as a STEMI or a STEMI equivalent, and do not fall under the umbrella of the classical STEMI criteria. And the classical STEMI criteria includes somebody that has signs and symptoms suggesting an acute coronary syndrome, and they have to have one of two major findings. First, they have to have at least 2 millimeters of ST segment elevation, so greater than 2 millimeters of ST segment elevation in one lead. So if they have signs and symptoms and ST elevation that exceeds 2 millimeters in a single ECG lead, that would be considered positive STEMI criteria, or greater than 1 millimeter of ST elevation in 2 or more contiguous leads. And a contiguous lead is contiguous leads are groups of leads that look at the same area of the heart. And the classic contiguous leads are leads 2. See if I can write this down at the bottom here. So you've got 2, 3, and augmented vector front. And they look more at the right side of the heart and the inferior wall of the left ventricle. And so these are often referred to as the inferior leads. All right. And then you've got leads V1 and V2, which look at the septum, the intraventricular septum that separates the right and left ventricle, and these are referred to as the septal leads. And then leads V3 and V4 look at the anterior wall of the left ventricle, the front of the left ventricle, so these are often referred to as the anterior leads. And then V5, V6, 1, and augmented vector left, or AVL, look at the side of the heart, the left side of the heart, referred to as the lateral wall. And then, of course, these correspond to different coronary arteries. For example, the inferior wall is more often supplied by the right coronary artery, whereas the septal and anterior walls are more often supplied by the left anterior descending artery, the LAD, and the lateral wall of the heart is more often supplied by the circumflex artery, looking big picture. So when we talk about greater than 1 millimeter of ST elevation in 2 or more contiguous leads, we're talking about these, right? So V5, V6, 1, and AVL are all contiguous, 2, 3 AVF are contiguous, and then V1 through V4 are considered contiguous. So if you had 0.5 millimeters of elevation in lead 2 and 0.5 millimeters of elevation in V4, that would not meet STEMI criteria because 2 and V4 are not contiguous with one another. All right, going back to DeWinter T waves. Because these do not classically fit into our classic STEMI criteria, they may be missed and misinterpreted, and that can lead to delayed or inappropriate treatment. These, however, as I explained in the last video, are now seen as equivalent to a STEMI, as a STEMI equivalent, quote unquote, by not only the American College of Cardiology, the ACC, but there have been papers published by the American Heart Association in their journal called Circulation, where this is also alluded to as well. So at this point, it is my argument that DeWinter T waves should be seen as mainstream, right? This is no longer fringe. This should no longer be debatable by anybody. This should be seen as mainstream medicine. This should be seen as identical to STEMI if you continue to use the STEMI versus NSTEMI/USA paradigm versus the OMI paradigm that I talked about in the last video. Okay, so let's take a look and see what these DeWinter T waves look like. Okay, so here we are. These are the 3 major things, and some people will have longer lists or shorter lists, but I'm just trying to condense this into some high-yield concepts. So first of all, you will present with ST depression greater than 1 millimeter in the precordial leads. So precordial leads are those unipolar leads that wrap around the heart. V1 through V6 are the precordial leads. All right. So here we're looking at V3. And you can see here is the baseline, and you can see here's my J point, and you can clearly see that the J point is below that baseline, and so this is ST depression, and you can clearly see that it exceeds, like, remember, one little box is 1 millimeter, and this clearly exceeds that 1 millimeter threshold. So check. We've got greater than 1 millimeter of ST depression in a precordial lead, V3 in this case, but we can assume that this is in additional precordial leads. All right, second, you're going to have a tall, prominent, and when I say prominent, what I mean is in relationship to the QRS complex. All right, the T wave is going to outshine the QRS complex typically. It's going to be much larger, much more prominent, and it is going to be the most prominent feature of the PQRST complex. That's what we mean by prominent. Generally symmetrical, upsloping T waves in the precordial leads. So you're not only going to have depression, but you're going to have tall. And so you can clearly see that this is a very tall T wave. You can see that the T wave is generally symmetrical. And you can see that it has this upsloping appearance to it at the beginning as it transitions from the J point into the T wave. And clearly it is involving or impacting the precordial leads. And it is prominent and large in comparison to the QRS complex. All right, so this is very classic de Winter T wave morphology that we're looking at here. So check. And then the third major thing that you will often find is reciprocal ST elevation. So you will have, or you often will have ST elevation with de Winter T waves, but you will have that in AVR, augmented vector right, which typically we don't use AVR in our standard interpretation of 12-lead ECGs. We often just kind of discount it. But in this setting, ST elevation, and that ST elevation is generally between 0.5 to 1 millimeter, is going to be strongly associated with de Winter T waves. So that is just stronger evidence that we are in fact dealing with de Winter T wave morphology if you see that. All right, so let's go ahead and just take a quick look at a 12-lead ECG. So if we look at this 12-lead ECG, let's go ahead and look at the precordial leads. So I'll circle them, V1, V2, V3, V4, V5, and V6. So you can clearly see that you've got ST depression. You can clearly see that you've got large symmetrical upsloping T waves in reference to the QRS complex. And if we take a look at AVR here, I am going to enlarge it. You can clearly see that you've got some ST elevation in AVR, which we will assume to be reciprocal to the depression that we're seeing in the precordial leads. And so you put all this together with signs and symptoms of an acute coronary syndrome, and we would say that this patient has de Winter T waves. And this, again, is equivalent to a STEMI. More specifically, we are concerned about an occlusion of the left anterior descending artery, which, again, is a pretty nasty thing to have because that supplies a significant portion of the muscle mass of the left ventricle. All right, hopefully this was helpful, and hopefully you understand de Winter T waves a little better, and hopefully you can begin to integrate this into your practice and look at this as an equivalent to STEMI. All right, everyone, thank you so much. I hope you have a great day, and I hope you have a great holiday season. as we move into that in just a couple of days. And if, depending on your religious or cultural practices, some of you may already be celebrating certain holidays. I believe Hanukkah began a few days ago. But be that as it may, I hope that you have a great holiday season, and I hope to see you all in the next video. Take care, everyone. Bye-bye.